Good morning. It's a pleasure to be here. We have a long day, and we know it's a challenging one. And we're going to spend the first part of it making sure everyone understands what's been happening and what we hope will be happening under this new initiative ending the HIV epidemic. And so we will hear from the people who know the most about it, both from the Department of Public Health and public health specialists, and from partners, because this has got to be a partnership. Most of all, it has to be a partnership with the community. But there are many agencies, many people who need to be involved, and we want you to know that they care and that they will tell you what they're planning to do and what additional resources we now have available for this work. I wanted to bring a few ideas from the Chief Operating Officer, COO, for ending the HIV epidemic, who is someone many of you know very well, Harold Phillips in Washington, who has a long history of working in the field. He is a person living with the disease. He is an urban planner. He is an exceptional human being. And he said, you're already ahead of the curve, and he expects you will probably stay that way in Los Angeles because you're already doing integrated planning. Many places are not yet planning together. And of course, this epidemic, ending the epidemic initiative, broadens that collaboration beyond its STD, other STDs, HIV. It's working, relating more closely to substance abuse and mental health issues. So he thinks that that's terribly important and hopes you will think about this allows for more flexibility and more innovation than was often possible with the fairly structured approach to how we used our money under Ryan White and under some of the CDC programs, Centers for Disease Control. Please use the flexibility and the innovation. Do a few game-changing activities, learn from the research and also from the experience. Think about, from your perspective, who else should be invited to the table. Think about how to incorporate training and, of course, PrEP. And really think about how you get people tested and linked to care, and also think about readiness for treatment on the part of populations that are disproportionately affected, such as young men who have sex with men who are Latino or African American or American Indian, who are disproportionately affected. And there will need to be support for people to keep them in care if we're going to have adherence to treatment, viral suppression, and U equals U. And I will let Mario explain those meanings. You know, if you are virally suppressed, you are not going to pass on the disease to someone else, but you are not going to get virally suppressed without supports. And one of the things that is very clear is, as Mr. Phillips says, people have been telling us what they need for 30 years one way and another, and sometimes the legislation didn't allow it, or the funding didn't allow it, or the resources weren't sufficient, or we just didn't do it. Now this is the time when both we need to know what the community feels it needs and we need to be able to respond and provide it. And I know that there's an effort around things like housing, which are huge issues. And if you see something that needs to be expressed today, we hope that you will find a way to do it. You have note cards. There will be times to ask questions. We will be doing a process of first hearing from the folks who are most involved in running this effort, and we will hear from key partners, and we will then always have a short period for you to ask them specific questions. Then we will have a sort of facilitated reflection discussion period after each of the two major panels, so you can ask broader questions, consider what you think this means, reflect on the process, so we get your input. If you don't feel comfortable or are not quite sure how you want to ask a question, again, put it on a note card, wave, one of the staff will pick it up. We will also have a small group period at the end when we will ask you to address particularly the community engagement piece and then report back. And please, if you don't get to say everything you think, write it down and give it to staff. It will be paid attention to. So, we are going to begin with our first panel. I think we should try to get people to come up, and I think you all know who you are, but Mario Perez, Rafael Dr. Landovitz, Brits Scathen, Marisa Ramos, if she's here now, Commander Michelle Sandoval Rosario, and Lieutenant Commander Jose Antonio Ortiz, if you would all come up so we can move from one to the other. And then this way, when you ask questions, they'll be right there to ask the questions of. One other thing, feel free to get up when you need to. The restrooms are out to the right. Most of you know that if you're commissioners because you've been meeting here. And we will, if looks as if you need some extra break or something, we will try to arrange it. We'll ask you to hold your questions till everybody's presented because otherwise we're afraid we'll get hopelessly behind. But do write down the question when you have it. Don't let us lose it. Okay? We'll begin. Are you, everybody there and seated? Okay, our first and in many ways most critical speaker is Mario J. Perez, who is the director of the Division of HIV and STD programs within the Los Angeles County Department of Health. And he's going to let us understand better this effort. I'm going to go sit down so you can very comfortably be here if you prefer. Oh, you prefer to be there? Okay, Mario.
Thanks, Emily. Buenos días. Thank you, Emily, for agreeing to facilitate. Let me start with a few thanks. Let me thank our partners at the Commission on HIV and under the leadership of Cheryl Barrett. It's great to have a full room this morning. I don't think the room has been as full to discuss and review such an important topic in a long, long time. So thank you, gracias to our Commission partners. I also want to welcome to LA in their formal roles, Commander Michelle and Lieutenant Commander Jose from the U.S. Public Health Service, who you're going to hear from. Many of you know that Atlanta, Dallas, and LA County were identified by the Department of Health and Human Services to be areas where we could deploy resources and advance the response to HIV. And so welcome to Southern California, both of you. We're really glad to have you. Marisa Ramos, the Acting Chief of the Office of AIDS, thank you for coming down from Sacramento and spending the day with us. We will not be able to make as much progress as we want without very strong leadership in Sacramento, and in particular the Office of AIDS and a lot of the other health agencies that support our work. I'm gonna ask Andrea Kim to raise her hand. She's in the back. Dr. Kim is the new HIV/STD surveillance coordinator for DHSP. She started October 1st. Some of you met her last month at the commission. And in her first 6 weeks, she's done a remarkable amount of work assessing and improving and understanding our surveillance systems and opportunities for improvement. And so I wanted to especially thank them. And Jeff, my boss, who keeps me in line, thank you for your support. So my job this morning is to spend about 20 minutes going through about 24 slides to sort of lay the foundation, mostly sort of 3 sections. What we've done since December 1st, 2017, when we released the LA County HIV/AIDS strategy, what's happened since, and then as we look prospectively, what we can expect to roll up our sleeves and try to tackle in the most integrated fashion possible. So we're going to hear from some academic partners. We're going to hear from CCLAC. These are all part of the response. I've said it many, many times. There needs to be a commitment to unparalleled transparency and accountability if we're going to meet these goals. And this is an opportunity for us to get re-energized. So those are the 3 things I'll be briefly reviewing: what we've done since the launch, a quick overview of the epidemic and the Epidemic initiative, and then how we're going to align the initiative with the LA County HIV/AIDS strategy. How many people have had a chance to review the LA County HIV/AIDS strategy? Okay, so 38% of you. All right, we got to work on the other 62%. So we have 3 main goals. The first is to reduce the number of annual infections to no more than 500 by 2022. Our current estimate, and it's an estimate that continues to get refined, that there's probably between 1,800 and 1,900 new HIV infections in our county every year. That's down from about 6,500 that we saw in the late 80s, early 90s. So there's been some improvement, but the improvement is far too slow. And so what we've said is we want to reduce that number of new infections over a 5-year span through a few different things. The first is to increase access to biomedical prevention, to PEP and PrEP. And our enrollment in PrEP appears to be going up. I would say also a little bit too slow. Maybe about 18,000 LA County residents are on PrEP. Very hard to measure PrEP persistence, how many people are on PrEP in November and may not be on PrEP in December. So we have to be able to measure that. We want to develop a undetectable equals untransmittable, U equals U campaign. There was a focus group, maybe it started 2 nights ago. There was one last night at the Trans Wellness Center to get community input on what a campaign should look like, what that messaging should be like. But we've heeded to the community appetite for more messaging around U equals U, so we want to do that. Target our response to the areas and to the groups most impacted by HIV. That's been a long-standing tenet of ours. We need to promote resiliency and protective factors in a way that makes sure that people stay HIV negative. And there are a number of workforce-related issues that we need to tackle. We don't have an environment where we are supporting the critical HIV, STD, public health, substance use, homelessness, workforce that is doing everything human possible to make a difference. And so we have to figure out how we develop and sustain a workforce preservation approach, and also one that values sex positivity, equity, and social justice. Many of you know that we often talk about syndemics. We often mention syphilis and gonorrhea, but meth, opiate, homelessness, being at risk for homelessness, homeless, insecure, are all other epidemics that contribute to our limited HIV progress. And so I think many of us understand that there's no way we're going to make HIV progress if those other epidemics and social conditions persist. And we want to increase the proportion of people, goal 2, who are living with HIV who are diagnosed to at least 90% by 2022. So estimate as of yesterday when Andrea and I met, could be as low as 6,200. Maybe it's between 7,000 and 8,000. Again, those numbers are being refined as we enhance our surveillance systems. And I think many of us recognize that as well-supported surveillance systems have been historically, there are still gaps that we need to work on. We want to normalize testing and make routine testing truly routine. We sort of talk about it, but we have a very scattered approach to routine testing, not just in California, but in LA in particular. And so thinking through that is really important. We want to increase the proportion of people diagnosed with HIV who are value suppressed to 90%. It's been persistent at about 61%. It's been pretty flat the last 4 or 5 years. We need to see that number sort of grow, and hopefully with this new ending the epidemic initiative, we can begin to see some of that. Let me go back to the diagnosis. The diagnosis is also tied to linkage to care, and as a community, we have to set the standard. Do we expect folks to get linked to care within 2, 3, 7, or 30 days from diagnosis? And when we look at those numbers, there's a lot of variation, okay? All right, so many of you are familiar with some of the community engagement work. The commission helped lead the charge here. There were a number of focus groups to identify service needs, and those are an ongoing part of the HIV response. Many of you know and were part of the health district presentations where we shared the LA County HIV/AIDS strategy and its elements, and we asked people to sign on and be partners. We also have the commission had meetings with the Board of Supervisors and their staff to promote the strategy, and then more recently there was a data summit. So a lot of data informs our work, shapes it, reshapes it, and so that hopefully will continue to improve in terms of sort of data reliability to inform our work. So there have been some new programs and some expanded programs, honestly, mostly in the Ryan White supported system. And we've been able to do that because the Ryan White system is a healthy set of resources that we can continue to sort of shape and reshape. And so we were supporting housing for people living with HIV in partnership with Housing for Health, who's here with us today. Thank you, Lippy. Thank you, Anna. So that continues to show very good progress. 125 people living with HIV have been identified and placed in supportive housing. That number obviously needs to grow, particularly when the latest estimate is that we have 1,309 HIV-positive homeless persons in our county. AOM and MCC continue to expand and be refined. We have no oral health contracts, and for the first time, we have 4 providers who can provide specialty dental services, really sort of in the spirit of providing a holistic approach to HIV care and treatment. And there's also home-based case management expansion. There are a number of RFPs, solicitations we call them, tied to different things. January 1, we expect, we will be recommending to the board that they enter into new contracts with between 48 and 52, 48 to 52 contracts, fewer number of providers to deliver HIV testing, STD screening, and sexual health express clinics, and a new pay-for-performance model. We expect that to drive the number of people who get diagnosed with HIV. We expect people to get linked to care much more closely or to the time of diagnosis. And we also expect to get a lot more people diagnosed and treated with STDs, particularly syphilis and gonorrhea, often precursors to HIV infection. We're developing a social marketing campaign that should be wrapped up in terms of development by the end of the calendar year. There's also a service pathway that's being developed. We're going to change the way we support transportation services. We're going to decentralize that, and we're going to let the 65 organizations that we contract with define how best to meet the transportation needs of their individual clients. And so that's an evolution that's been a little overdue, but now finally happening. And then we have to think about the RCFCI, residential care for chronically ill and transitional residential care facilities. We are concerned that the housing stock is actually shrinking. And in an environment where we should be able to grow the housing resources for people with HIV, due to mostly economic issues, having providers acquire access to housing units has proven very, very difficult in the last several years. And so we will continue to work and strategize there. I'm going to fast forward a little bit and go to the next section. So in February, something quite frankly unexpected happened. The administration announced a new commitment to end the HIV epidemic, sort of under the guise that we finally have the tools and resources to really sort of end HIV in the next 10 years. And so that was welcome news for all of us. But what it also did is it made us sort of press the big pause button and say, okay, so we've launched LACHAS, but there's a new infusion of attention and resources and personnel who are going to be able to sort of help us do things better and hopefully more quickly. Let's sort of regroup. And so this convening today is part of that regrouping. So I won't spend a lot of time on this because I trust that our partners at the U.S. Public Health Service will also review this. So 1.8 million Americans have been diagnosed with HIV since June 5th, 1981. 700,000 of those lives have been lost. There's about 1.1 million persons living with HIV in the United States. A financial impact of about $20 billion tied to healthcare spending. And then over the next year or the next 10 years, if nothing changes, then we are likely to see 38,700 persons in the United States get HIV every year. And so obviously the goal is to not have that happen. So during the State of the Union, there was an announcement tied to a Plan for America 10-year initiative reduce new infections by 75% in 5 years, by 90% in 10 years. And it called for a cross-agency collaboration with all the key partners. The notable absence, I've said it publicly, I'll say it again, is the Center for Medicaid and Medicare Services, the largest payer of healthcare in America. But we know that CMS is at the HHS and in the epidemic leadership table, but they're often not explicitly mentioned on the federal summaries. 4 pillars: diagnose all people as early as possible. So for us, that means there's between 6,000 and 8,000 Angelenos that need to get diagnosed. Treat the infection rapidly and effectively. Prevent new transmissions through 2 major interventions: biomedical prevention. It says PrEP, but I think we also recognize the role of PEP in that, and also syringe service programs, and then respond quickly to potential HIV outbreaks. Many of us know about the outbreaks in Appalachia, in Boston, in Seattle, and obviously we do not want an outbreak locally, but I think we need to develop the infrastructure to make sure that we have alert systems and interventions in place to not make that happen. So there's 48 counties, DC, Puerto Rico, and 7 states, all in the South. Combined, they represent where more than half of the new infections in the United States happen. So LA County is one of those jurisdictions, along with 4 other Southern California counties: San Diego, Riverside, San Bernardino, and Orange, and then 3 Northern California counties: San Francisco, Alameda, and Sacramento. So some new resources. So there's a 1-year planning grant that's in effect. It's a $435,000 grant from the CDC to LA County that allows us for 12 months to really sort of enhance the planning around ending the epidemic. And so that is underway. More recently, there was a 5-year funding opportunity. Our partners at HRSA, the Health Resources and Services Administration, we submitted an application asking for $56 million over 5 years to do some pretty significant enhancements to our work. And we should know probably early 2020 what that funding level ends up being, and then we'll regroup once we learn about that. The HRSA application really focused on treatment and response. We do expect a funding opportunity announcement from our partners in Atlanta at the CDC to be released soon that will focus on pillars 1 and 3, the diagnose and the protect pillars of the initiative. So those resources will help catalyze and support and undergird a number of things that we want to take to another level. So at some future meeting, I think it would be good, once we have a clear sense of the budget level and once we sort of negotiate the budget with our federal partners, what we expect to invest resources in over the 5-year period. So we could do that today. It would take us a little bit of time, but I think at a future meeting, in the spirit of transparency and accountability, we need to share with all of you where the resources intend to go. So there's also technical assistance systems, and there's also going to be some supplemental funding to the very, very important network of community health centers across the country, including in LA. So we're really glad to hear from Louise McCarthy later today around how the network of FQHCs and community health centers will embrace and support and provide a new level of HIV-related services, in particular biomedical prevention. I'm going to skip the slides tied to the supplemental research grants, but our partners from UC San Diego are here. Rafi, we'll hear from Rafi also in a few minutes. But California did really well, both Northern and Southern California, in terms of being funded to think through some very important research and evaluation questions that you'll all hear about. So I'm going to skip through those, and then we'll tackle the last slide, or the last set of slides. Julie, how am I doing on time? 10 minutes. Oh, great. Let me go back. I'm kidding. So how can we align our local strategy with ending the epidemic initiative? How can we plan and implement at the same time? And who needs to do the work? I think what's been very, very apparent is that we need to sort of grow the expertise and the workforce and sustain that over the next 5 to 10 years. And so all of us need to be part of that work. And the first step is going to be to look at the data and what do we know. So I'm going to walk through a few slides to sort of tell us what the state of our work is. But our data systems need to improve, they need to modernize, and we need to use data in a way that is actionable more quickly. And so as Andres says, data to action. And so how do we sort of develop that infrastructure and resource and get data out to all of you in a much more efficient fashion? Okay, so we know a few things in terms of some of the other epidemics. Chlamydia is going up by about 34% over the last few years. About 65,000 cases of chlamydia in LA County. Syphilis up by 189% over the last several years. 54 cases of congenital syphilis diagnosed last year. About 7,000 cases of syphilis, mostly among MSM, but over 1,000 cases of syphilis among women. Syphilis and HIV, when we map them out, are essentially co-located geographically in terms of those cases. And so I think we have to figure out how we dramatically improve our syphilis response if we want to have HIV success. The HIV rates are going down, a decrease of 22% over that time frame, and gonorrhea is up by 182% over that 9-year time frame. And so things are, for the most part, going in the wrong direction. HIV, we're making progress, but it's too slow. So we have the care continuum where we compare the United States versus LA versus New York City and King County. Obviously, very different areas geographically. We often talk about geography when we talk about LA, 4,000 square miles, 88 cities, 2 mountain ranges. But this gives us a sense of sort of how we're doing. So if we look at the red bars in terms of sort of diagnosis, higher than the US average, but lower than New York City and Seattle, King County. Also lower linkage to care rate. And again, we need to agree that linkage to care in 2 days from diagnosis is the standard and not 30. We have a lot of data on the 30-day linkage, it's about 61%, but it has to be sooner and higher rate of linkage. And then we also have retention in care and viral suppression. And I mentioned 61% a little earlier. For anyone who's had at least one visit with an HIV doc in the last year, the viral suppression rate goes up to about 85%. But this is a reflection of everyone in our county. So the prevalence of HIV among MSMs by race ethnicity, we see a few disparities. Overall, it's 21%, so 1 out of 5 MSM or HIV positive, higher, more than 1 out of 3 Black MSM, and about 18% for Latino MSM, 15% for white MSM. PrEP use among large jurisdictions, so LA County, it's about 37% usage of PrEP among MSMs. We want that number to be much, much higher. Syringe service programs, on average, sort of one metric, about 17 syringes exchanged per person, but there are plenty of other areas where that number is much, much higher. And so I think many of us agree that we have to really sort of increase and expand the menu of services and the breadth of syringe service programs throughout our county. And we would all benefit from a modernization and more support for those programs. Homelessness, so the rate of homelessness in LA County is not as high as other parts of the country, including New York, San Francisco, and Seattle, King County. But the sheer number of homeless, the 59,000 homeless, obviously needs to be tackled, and there's a number of initiatives that we should all be aware of. So this is the last couple of slides. What needs to happen next? We have to align all of our metrics. We all need to make sure that we're measuring the same thing so we know if we're performing or not performing compared to the metrics we outline. We're going to have a new epi profile. Andrea is working on that. There's a tentative sort of December release date, sort of a new improved look and feel to that epi profile that I think will be welcome to all of us. We need to complete a situational analysis, so you have some data points here that basically describe, okay, what's the situation in LA County, what's fueling HIV, what's hampering progress, but that needs to be completed. We need to submit a draft plan to the CDC by December 30, 2019. Now, let me add a caveat here. The CDC and HRSA and our other federal partners expect us to do robust community engagement and community mobilization. We could not agree more. In the next 6 weeks, we are not going to be able to do that robust community engagement and community mobilization. So the submission in December will be a down payment. And we've negotiated that in 2020, there'll be a full-fledged, updated plan that really incorporates all of the community mobilization, community engagement efforts that all of us collectively agree to spearhead, okay? So when people hear in January at the commission and as part of the DHS report, I say we submitted our draft plan, don't fret. We're gonna have another submission in 2020 that is much more complete. And so that expanded community engagement with stakeholders is really, really important. Okay, so we're gonna revise the plans over the next following 10 months, and then we're gonna implement some rapid programs and services to address gaps along the HIV continuum as early as March 2020, when we expect the new funding to roll into LA County, okay? So we're gonna end with this, because this is a really good summary. So if there's one slide out of the 27 you have, take this one and put it on your wall. Make a smaller version and tape it to your Apple laptop. We need to do these as quickly as possible. An organizational assessment, so really three main buckets here. The right data, the right tools, and the right leadership combined will get us close to the finish line. So an organizational assessment, a really honest assessment of organizationally, in the broadest terms, how equipped are we to really move the needle? Increased staff capacity. In some areas, we just do not have enough staff to do the work. We don't have enough public health investigators to promptly investigate every new HIV diagnosis and every new syphilis diagnosis. So we have to be honest as a jurisdiction about what capacity we have. New data system. We're gonna move away from CaseWatch. Should be welcome news to all of you who use CaseWatch. But the systems need to talk with other systems. And so the replacement really needs to be a system that can interface with all the EHRs that are in place. So when someone gets diagnosed and linked to care and sees a doc, it's real-time information to all of us, not waiting weeks and months on end. And so if we're really gonna be making progress, we really have to be much more sophisticated. And there's a new prevention data system in development that will also integrate with the HIV testing, the STD screening, the tuberculosis, and other morbidity systems. And we expect that to be launched in 2021. It's well on its way. Surveillance and care coordination also needs to happen, but we have to figure out in a state like California how we can share that data in a way that's aligned with state law. And so we will need some policy interventions to achieve some of this, including a review of all the data sharing constraints that exist that preclude the health department from sharing valuable client level information with all of you. So if we want data to be actionable, it also needs to be shareable. The right tools, we talked about staff capacity, linkage to care for newly diagnosed. A lot of folks are being diagnosed, not linked to care quickly enough. We need to broaden that service. Patient-centered options for HIV care need to happen. And then obviously competing demands for patients. And then the right leadership. So we've proposed an Ending the Epidemic LA County Steering Committee and some subcommittees. Obviously, stakeholder engagement needs to happen and be sustained. And we also need to make sure that consumer involvement and empowerment is a cornerstone of our work. And so this is a blueprint and framework to make sure that we go from aspiration to operation. And so I'm going to end there.